Hi everyone, and welcome back to Instagram Live with Intimate Rose. I'm Dr. Amanda Olson, the President and Chief Clinical Officer here at Intimate Rose, and today I am so lucky to be joined by Turning Teen. I'll be joined by Dr. Carrie Leff, who is an internist and pediatrician who has gone on to become certified in menopause as a specialist and care provider, and by Lisa Klein from Turning Teen. And they are going to share with us, provide education to parents and families of teenagers who are going through hormonal changes and how to navigate that space, and also those transitioning in the menopause space. Hi.
Hi there, Dr. Klein with Turning Teen.
Hi, Dr. Klein. How are you?
Well, I'm good. I'm in the car parked. Don't you worry. But, I'm working mom going from activity to activity. How are you?
I'm good. I am familiar with that. And if you want something done, you give it to a busy mom.
That's it, 110%. So now we have to find Carrie.
Yes.
She needs to request to join. Is that right? Did she?
Yes. Let's look here.
I can text her. Hi, everybody that joined us. Oh, there we are. We found Dr. Leff.
Hi,
You're
I can't
there. You
see.
did it.
I did it. Oh my God. I was very nervous about the technology, which
You did
is
it.
unusual for me.
Well, it's Halloween. Sometimes spooky things happen with technology and we can't explain why. So that's a founded and very normal response.
For sure. Thanks for having us.
Thank you so much for being here. I was just sharing that you all are providing this amazing service to families of teenagers who are going through hormonal changes and how to navigate that space, and then also recognizing that oftentimes as women, when we are helping our teenagers navigate that space, we are also right at the prime of perimenopause and menopause and experiencing changes ourselves that sometimes feel like we're in puberty again.
Yeah. Yeah, for sure. We started Turning Teen like 10 years ago to help transition. We started with girls, but girls and boys into puberty without shame and embarrassment. And at that time, I wasn't particular, like I was seeing women in clinic, but I wasn't doing as much like women's health or menopause as I am now. And so then there, with the rise of interest in menopause, it was a natural extension as I practice menopausal medicine, because there are very many parallels from puberty to menopause. So we call it surviving your second puberty. So it's your second puberty, but then we also know that sometimes at the same time you're trying to survive your other second puberty experience, which is that experience of your children. So that's really hard and confusing, and sort of are on the opposite ends of the fertility spectrum.
Absolutely. So, where do you usually start with your education? Do you start with the teenagers, or do you start filling the cup and helping provide information for the mom, or is it all at once?
So
Anywhere we can.
yeah. So if we're talking about kids in puberty, we do in-person classes and then live webinars with groups, and also small group like private programs, either in person or virtually. We also have now extended our focus for Turning Teen into schools, because since the pandemic, what we've realized is, well, and social situations have changed. There's just a lot more on the line, and it's a lot harder for teachers to be teaching about sexual health. And it's really just like not a natural extension of their training, in our opinion. And so in order to like kind of make it easier on the school, they can outsource it to us, and we come in and provide like medically relevant and accurate information without shame and embarrassment. For the school. And so that's really been a focus of ours in the last year or two.
That's amazing. And your original training was that as a pediatrician and internist, and then
Yes, so
you
on both. Good
added,
job.
yes, and that you've added the menopause certification.
Yeah.
So, what does the education look like for those of us who are starting to experience those hormonal changes?
Yeah. Yeah, so what I began to realize through the work with Turning Teen and then with my in-clinic work is that with the rise of interest in menopause, there has to be like a baseline understanding for women, or it's much more helpful when they have a baseline understanding of menopause, the stages of menopause, how we can experience it, what symptoms to expect that they may have or they may not, and what treatment options are available should they decide to pursue those routes. And we just have found it, or I've found it specifically, just like a very effective technique is to educate people through like the Turning Teen platform that we have already developed. Because remember, the moms that we started with were probably like 40 at the time when their daughters were going through puberty. And so now most of them, if not all of them, are perimenopausal. And so trying to give this like a this webinar that we're doing, or just education really, in a similar way that we've done it with Turning Teen. It's very approachable, it's easy to digest, it's meant for the average woman, and it's sort of in a non-serious way and really very open, body positive way.
I love that. And so what are, there's so many symptoms. I think there's been 45, is that correct? Symptoms that have been identified as typical of perimenopause and menopause,
Every time I hear a number, it gets
which
extended.
is,
Like last time I heard 67 or something random. So,
my foot
yeah, I
hurts.
mean, there's
Is that
lots.
associated?
Yeah, I don't know. There's a
I,
lot.
I
Yes.
just I just heard something about frozen shoulder,
Yeah.
Carrie. I
Oh,
forgot. I'm going to ask you after the fact, or maybe I'll ask my question at some point. But I was like, really? That's
I
menopause?
know.
Maybe.
Isn't that
That,
crazy?
that was actually part of my original curriculum 15 years
Oh,
ago, as is
okay.
from a physical therapy standpoint, is that recognizing the correlation between frozen shoulder and
You're a
menopausal women.
trailblazer then.
That's
I try.
awesome.
It was my instructors truly. But what do you find are the most distressing ones? The ones that people have the hardest time with?
So it just depends, I think, on the patient that we're talking about. You know, we are getting different kinds of patients now that menopause is in the limelight. Like we're getting some patients that are older and have been looking for menopausal care for many years. Now we're interestingly getting, or I am, patients that are much younger and actually probably premenopausal, and maybe having symptoms, not symptoms related to hormones. And then we get like that middle of the road sort of perimenopausal woman who's very symptomatic, whether it be with hot flashes and night sweats. I mean, midlife weight gain is a huge problem for women. Mood changes and sleep disturbances really wreak havoc on women's lives. And then sexual issues present a really big issue for people um, in their marriages, and sexual pain, which isn't, I think menopause is talked about a lot, but every time I talk to a woman and I say sex should never hurt, it's more surprising to them than expected.
I agree wholeheartedly, and that's one of our focal points in pelvic physical therapy, and certainly here at Intimate Rose, we've got dilators to help. I brought a couple up here to help with managing some of the tissue changes, and vaginal moisturizers as well, but recognizing that we're managing psychosocial issues, and we're managing somebody who's exhausted, and we're also working with the tissue itself, which often from a medical standpoint, we're working with providers such as yourself to ensure that they're getting adequate supplementation of estrogen and their appropriate hormone replacement therapy for those that are candidates too, in addition to using the dilators and working with the pelvic floor.
Yeah, I think that's so great. And, I introduced the idea of pelvic floor physical therapy a lot. And a lot of my pelvic floor physical therapists at my institutions have become my patients and big advocates. And I'm like, we need, like, be part of the army of women, of spreading the message. And they certainly are, because once they become engaged in their own perimenopause or menopausal journey, then they have like the perfect, sort of patients to talk to them about. But what I find with patients who are super unfamiliar with the idea of physical therapy for the pelvic floor is they're very taken aback by that it even exists. Sounds a little weird to them, and what is that going to look like? sometimes can be met with fear or hesitation. And so actually, when thinking about coming on here, I thought I would ask you about what how you would recommend that a physician describe pelvic floor physical therapy to their patient if we find that they have pelvic floor hypertonus and would benefit from it. And then I can certainly tell you what I say, but I just would love to hear that like elevator pitch from you.
Me too.
Oh,
I was going to ask that. I was like, can we turn this really quick as a physician who works with kids? And I've learned so much, obviously, about menopause from Carrie, working with her through turning teen. I'm even learning a little more about, gosh, I probably have some teenage female patients that would benefit from pelvic floor physical therapy. And we are not, I think, as physicians as a whole, I'll say at least as pediatricians, knowledgeable enough about what you do. So lay it out there for us and lay it out for our viewers.
happily. So pelvic health physical therapists and occupational therapists are highly trained. So we go through additional training to be able to evaluate the pelvic floor and issues that relate to the bladder, the bowel, and the vaginal tissue itself. We also treat men. And we treat throughout the lifespan. And within that, some pelvic health physical therapists and occupational therapists really niche down and treat individual segments, and some of us just treat all of the above. But we work with patients one-on-one to identify what the issues that they're having are and what their goals are. And our whole entire plan of care is going to be tailored to meet them where they are and to get them to where their goals are. We do a very comprehensive evaluation that includes looking at their back, their hips, and their pelvis. Our pelvic floor exam involves an internal vaginal assessment, but it doesn't need to be done on the first day. We can get to know each other. Some patients have a history of trauma or abuse or other medical conditions and they're not feeling ready. We have lots of tricks up our sleeves in order to get an understanding of what the current issues are. We're interested in knowing, are your pelvic floor muscles strong enough? Are they flexible enough? Do they have good coordination? Because oftentimes with being pregnant or having surgeries or undergoing health changes, there's changes to the coordination of those muscles that affect urinary incontinence and how we're having bowel movements, and they definitely affect sexual function. So whatever the goal is, first of all, we've heard it before. There's nothing we haven't heard. And second of all, we are specifically interested in helping them meet that goal. So we use some manual therapy. We use tools. Dilators aren't always recommended for every single patient, but they might be part of the mix. It might involve some exercises pertaining to their condition. So if their pelvic floor muscles are too weak, we're going to give them exercises to specifically strengthen and coordinate them. If they are too tight and they have scar tissue or trigger points, we're going to be doing gentle exercises to help train those muscles to relax. And then we also have visuals. We use real-time ultrasound in some clinic settings and biofeedback. And then we empower that patient once they reach their goals to manage on their own so that they are not needing appointments all the time.
Yeah. I think that one of the things that, you addressed most of the things that patients push back on, which is like, that sounds so weird. And is that going to be an internal exam? And is it just going to be jumping right into it? And so those are some of the things that, I say that the people who do this have a passion for pelvic floor health because they need to seek out that extra training. And so they have quite a way of introducing this, and you have to consent, and it's not like the first minute you're going to be asked to undress and they're going to do like a full assessment. But one of the things that I find is helpful, especially for patients with sexual dysfunction, is say like, I say like, this is a natural thing. If you pulled a muscle in your back, that I'd send you to physical therapy. But I think that the point about like, vaginal deliveries that could have gone, not in the exact way, that are patients who have had surgeries or have rectal issues, constipation, we don't really sort of make that connection all the time. And so sort of letting patients know that the goal of pelvic floor physical therapy, like back, it might be for mobility and strength, but one of the goals for pelvic floor physical therapy is painless penetrative intercourse, if that's, which is something that a lot of times they think is just not possible. And what a great goal to be able to like kind of reassure them that they can work towards.
Absolutely. It is, there are solutions. You don't need to live that way, and it is worth it to go through the process because you deserve to do all of the things and have a very fulfilling life, including a sexual life, which is part of being a person.
Would it be correct to say, like, because this is what I've noticed, that most of my patients like have like a plan of care that's about 12 sessions, 12 weeks in duration? Like, I think for like, I just had a medical student the other day with pelvic floor hypertonus and really,
Carrie, can
would
you
be,
define what that word means, because you've used it
yes,
now a couple of times?
sorry.
That's
So
okay.
what I screen for mostly, like I guess I should probably be screening for pelvic floor weakness, but what I come across mostly is pelvic floor tightness,
Yeah.
causing from something. It's often from sexual trauma. It can be from changes from menopause. Like if you've got a lot of real thin vaginal tissue or narrowing of the opening to the vagina, you start to have pain with sex, and the muscles have memory to them. And they're like, oh, well, if penetration hurts, we want to keep that away. We're going to become really, really tight and strong and resist that, just like back muscles do, the strap muscles in the back. And then you have two problems, right? So like that's what I find a lot in the patients who are postmenopausal, that they've got significant what we call genitourinary syndrome of menopause, which is change in the tissue. But if it's gone on for a long time, then they develop pelvic floor problems and tight muscles, leading to a second problem with penetration.
Absolutely. That's what we're seeing on our end as well. And it's really prevalent in that patient population. We're also seeing it in the Gen Z and the younger generation now as a byproduct of anxiety and stress. And if they've had one negative experience, as you said, those pelvic floor muscles are going to say, I'll protect you. I will make sure this never happens to you again. And it's involuntary. They're not doing it on purpose, but those muscles guard, and then we work to retrain. And that's where we're creating that new coordination system. And you had mentioned 12 visits. That would be definitely an average, depending on current medical status. So, the different things that they are experiencing, and then the length of time that it's been a problem. That plan of care might be a little longer. If the person's been in chronic pain for a long time, we might expect to see them weekly for 6 to 8 weeks and then taper off a little bit, but hold that relationship longer. And so we're giving them lots of things to do at home, and they're working with the tissue and training new habits, and then we recheck and we progress. We can see people a little bit longer, and some people, once they learn, they learn the new habit and they're done quicker. So it could be shorter period of time and it could be longer.
Yeah, I think that like sometimes depending on how motivated the person is, to if they don't have a lot of time, even just, a couple sessions to introduce the idea, and then maybe them purchasing something from like you guys, or something like a wand or a dilator, probably could be used at home within a refresher, like if they need it, if time is really limited.
Tell us about your show and tell over here. Let's see.
She
Just hold
mentioned
on.
one. So this
Okay,
is, we
wand.
have,
I saw the dilators.
that's right. So we have 5 wands in our wand family now, but the wand is to do myofascial release and tender point release of the pelvic floor muscles. So just the same way as you were talking about, the muscles become really tight, they can be overactive, they can develop knots just the same way we would get in our neck or our back, and you push on it and it kind of zings and it's very painful. That is the same principle in the pelvic floor muscles. They can get too tight, they can have knots in them. So the wands are developed to allow people to reach inside and mobilize them, and it really empowers them beyond physical therapy to manage their pain independently. And eventually they do graduate, and then they can be independent, and it just is a way of maintaining it to make sure that they don't experience that pain again. But there are 4 that are all shaped the same way. 2 of them vibrate. The turquoise and the blue vibrate. Yellow is temperature therapy, purple is original, and we have a brand new orange bendable wand that is extra long. So for pregnant patients, they can reach around and allows them to meet the contours of their unique body. And then the dilators we talked about, they're just a tool to help train the brain, the sensory system, the coordination of the pelvic floor and the vaginal tissue. So if they do have genitourinary symptoms of menopause and the tissue has become a little less flexible, things are feeling screechy and scratchy instead of slidey and glidey, the dilator is used to help gently mobilize that tissue, and they gently progress up until they reach their goal size. Goal size is dependent on the patient. So if their goal is pain-free speculum exam, they might be done around dilator size number 4 or 5. If it's pain-free intercourse, then 6, 7, 8, depending on the size of their partner. If they're not dating at the time, we just recommend roughly around 6 or 7.
That's good information.
Fascinating.
Thanks. I know.
Yes. We also have vaginal weights for strengthening the pelvic floor.
Well, you
So
talked about those
What is
because
it called?
I did they're vaginal weights, like so you can have pelvic floor hypertonus, which is too much, and then you can have weakness, which is too little. And I saw those at the Menopause Society meeting. So I like, will you walk through those? I have to say, like I said, I don't screen for weakness probably as much as I should. And of course, there's urinary incontinence issues and stuff like that. But yeah, I'd love to hear about weakness.
absolutely. So just over time, and especially with loss of estrogen, overall systemically, our muscles can get a little bit weaker. Health changes after delivery. So just the same way as we would strengthen using a resistance band or some light weights, and then progressively add resistance to get you stronger. Vaginal weights, likewise. The goal is not to like lift a surfboard or lift a dumbbell with your pelvic floor muscles. The goal is to have good strength and endurance.
We have
and
seen those
responsibility.
videos though.
Yeah.
Like,
This
yeah,
is
they're
like
out there.
the
That
best
like
clip.
sounds
I
like,
cannot
yeah,
wait.
not a good
Yes.
idea.
Okay.
We're interested in function, and
Right.
function involves good responsive muscles that can contract quickly to ensure that you don't leak urine when you cough, sneeze, laugh, or to help lift up pelvic organs if you've noticed a little drop in descent, pelvic organ prolapse. So the white weight is the lightest, and as the color pink gets darker, the weight gets a little heavier. So you just put it in. My recommendation, my favorite recommendation, especially for busy people, it goes in just like a tampon, sits right above the pelvic floor, and then you take a shower. So for 10 to 15 minutes, you're doing different body positions. Your pelvic floor muscles are engaged. It's not a clench. They're not maximally contracted, but they're just engaged. You're getting some awareness as to where they are. And then after the shower, you take it out, wash it, and you're done. So it's a little endurance work, a little power work, because you're getting all these different body positions as you're washing your hair and washing your feet. And then when it gets too easy, you just move on to the next one. So it's very clear to see your progress. It's very self-explanatory. And all the tools come with a guide in the box with the product. And then on our website, each tool has its own guide with videos that I've made and instructions so that people can manage at home.
Super cool. So I'm going to break this down for the non-medical people, which I kind of feel like a non-medical person right now. Okay, you guys, this is just fascinating all to me. So a female that has urinary incontinence, folks, right? That means you pee a little on yourself when you laugh and
Stress incontinence, right? So that's like cough and
thank you.
yeah.
That's another word. Typically, I'm assuming means you have a weaker pelvic floor, which means these type of weights that she was just showing you are to help you strengthen your squeeze, your Kegels, right? To prevent you from peeing on yourself without having to have a surgical procedure, etc. Did I
Yes.
summarize that correctly for our friends?
Yes.
Okay.
And so the key word there was typically. Sometimes people that have pelvic floor muscles that are too tight, as we've talked a lot about, can be experiencing urinary incontinence because they lack flexibility. Mm-hmm. And in that case, they're going to get managed with some manual therapy and some myofascial release to ensure that they have good flexibility and support and mobility. So it's not always a one-to-one correlation of incontinence with weakness,
Sure.
but
okay.
there tends to be a common
Now,
accommodate.
Carrie, as a certified menopause provider, classic case comes into you with this. Are you telling them to go potentially buy these weights, or this is all you need to see a specialist in pelvic PT to talk to you about this and teach you about this, and then you graduate to doing your own homework at home, right?
Yeah, I think like, I mean, we do the best that we can to address everything in the office, but imagine like all the things that we talk about in a visit and how, sort of hesitant people are to come back for multiple visits. We do an exam to try and, especially when somebody has sexual pain, and I think that I can't, well, I haven't personally been to pelvic floor PT, though I have been to conferences where these lovely human beings even become teaching patients because they're so passionate about the pelvic floor, which is amazing. So I've interacted with a lot of them before, but I don't think that my training is like enough for me. Just like I couldn't give someone like as good of back exercises as a
Sure.
PT, I don't think I can do as good of a job as they can. So often my sort of sell, if they're hesitant, is like, hey, just go visit with these people. They're lovely. I really have never had a patient say that it wasn't worthwhile. And if you can't do the entire treatment plan and you're young and super motivated and very busy, then they can give you a lot of stuff that you can do at home after meeting with them once or twice because they have dilators. But you don't want to assume something, because like if you assume a patient has pelvic floor weakness and they have pelvic floor hypertonus, or you can actually do like you're doing them a big disservice,
Right.
because also there's asynchrony, and she could talk about that. Like, you might guess that they're like that they should be tight, but they're, the bladder is one way, the vagina is one way, and then around the rectum is another. And so they are really the experts on that. So our job, what I see my job is to identify the patients that would benefit from pelvic floor PT as a screener.
Love that.
Cool.
I would say that at least in my institution, I don't think there's like a ton of people referring to pelvic floor PT. It's probably like a isolated group of people that are referring often, is the way I sort of see it. I don't know if that's true, because they're screening to recognize the issues. Do you think that's true?
I think so. And I think the more we educate your peers and our peers as a whole, the more that screening is going to kick in so that we can help people faster.
Yeah. I wanted to just get back to the education around menopause and just talk a little bit about the webinar that we're having on November 19th at 8 p.m. Eastern Standard Time, which is about like an hour to hour and a half presentation just about menopause. Just really education, non-biased, science-based, to learn about what to expect. So really for any of your midlife women followers, whether in menopause or not. I always say that every day, even if you are not menopausal yet, you're walking towards menopause, regardless of the way that we look at it. So that baseline education, just like with pubertal changes even early, is really beneficial. And we made a coupon code for your listeners, and hopefully we'll post that after this, which is Intimate Rose, for $10 off of the webinar when you register. And we'd love to see some of your followers there, and we'd love to see you there to just kind of have that baseline information to translate to patients, because we can't see everybody.
That's where the internet is such a beautiful thing. And thank you so much for offering that discount. So $10 off, code is Intimate Rose for the upcoming webinar in November 18th.
19th.
19th. I'm so sorry.
That's okay.
19th.
Tuesday.
Registration is online at turningteen.com under, live webinar workshops.
We're going to post like more graphics today. We'll send those your way with your code and everything. So your listeners, hopefully you can post that as like a static post so your listeners can take advantage of that. And I'd love to see them there and see you there.
We would love that as well. And thank you so much for coming on and sharing your expertise, both of you, and for all the amazing work you're doing. Is there any final message you would like to leave with people in closing?
Lisa, do you want to talk
Well,
about?
really quick, I just want to ask, where are you located? Like physically, where's your clinic? I'm just, for anyone listening who needs to find you, because you
Yes.
seem fabulous.
You are so sweet. I'm located in Southern Oregon,
Okay,
and
friends, there you
yeah,
have it. Southern Oregon.
yes. And I'm available to answer questions at support@intimaterose.com. So if people have more questions about pelvic physical therapy, we're always here to support you. And my primary work now is in developing wonderful new tools here at Intimate Rose and educating. And I do a teeny tiny little bit of patient care still. So yes, Southern Oregon.
Cool.
And how about you both? Where are you located?
We're both in southeast Michigan, but we're trying to expand really our teachings like more online because the in-person space is just so much more challenging. And like you said, we just want to reach more people. We've put our heart and soul into this, and so reaching more people is like what we're about.
Absolutely. And we are here to help elevate that message and help people know where to find you all as well.
Thank you so much.
Thank
This
you.
was
Nice to
fun. Let's do
meet
it again
Yes,
Yeah.
sometime.
let's do it again. Absolutely.
Okay, have a good weekend.
Have a good rest of your day and weekend.
Okay, bye.
Bye,
Bye.
Bye, Lisa.
ladies.